You may be asking, why in the world is a pelvic floor physical therapist talking at an MS conference? And what I would like to challenge you during this talk is, I think what happens that with patients with MS is the thought with bowel and bladder issues is give them medication. Give them something to stop that overactive bladder. Give them something to decrease that urgency and frequency. And what I would challenge you with is a lot of times issues with bladder and bowel in MS tend to be more behavioral and tend to be pre-existing from other pelvic floor issues. So there is often something that you can do from a physical therapy standpoint that will allow them to be off of those medications that have some pretty horrible side effects. So if you can send them to a pelvic floor PT, it might be a lot more desirable to them. The other thing is that I want to make people more comfortable with talking about bowel, bladder, and sexual function to your patients. All right, so the pelvic floor room is often known in the clinic as that room, and you don't want to know what goes on in that room. I think it is pretty telling that when Jayco comes to visit, people hide out in my room because they know Jayco won't go in there. You want to be comfortable asking your patients about bowel, bladder, and sexual functioning. I talk about it all day, so sometimes I forget that it can be an embarrassing topic. People don't like to say the words vagina and penis in polite conversation. I do in restaurants. It's fine. And ultimately, a lot of patients don't know where to go for some of these things. They don't know who to ask. So do they ask their MS doc? Do they ask their primary care physician? Do they talk to a urologist or a gynecologist? And so often what I see is that patients just don't talk to anybody. In fact, I have more patients that talk to their physical therapists, and it's usually because their PTs are with them 3 or 4 times a week for 45 minutes, and they'll be like, hey, I gotta go to the bathroom every 10 minutes in my therapy session. So that's kind of what I'm gonna cover today. So what does a pelvic floor therapist do? Way more than just Kegel exercises. If my entire job all day consisted of saying squeeze and relax, I would be really, really bored, okay? It is way more than just Kegel exercises. Now, I often joke that generally I treat from here to here and don't ask me about anything beyond those 2 areas. But we really do treat everything. Anything that happens from the pelvic floor in the pelvis, including urinary incontinence, fecal incontinence. Pelvic pain is another huge one that we will see. So that covers all manner of evils, everything from pain with intercourse to just generalized pelvic heaviness and pelvic pain. We treat constipation, which everybody has been constipated sometime in their life, and if you are constipated, it's really hard to concentrate on much else when you're constipated. Pelvic organ prolapse, which is something that primarily happens in women, especially women that have had children, and then sexual dysfunction. So that can be anything from, again, pain with intercourse to anorgasmia or difficulty with erectile dysfunction. So there's a lot of different things that a pelvic floor therapist does. So this is my bread and butter right here. This is the pelvic floor. Most people don't realize they have this many muscles in their pelvic floor, what those muscles do. I even have women that don't know that there are 3 holes down there, not just 2. I have a lot of men that don't know women have 3 holes, not just 2. So it's a lot of education that we do. But I put this picture up because the pelvic floor is complex. It is a complex set of muscles. You can see on the picture on the left, it's showing you both the superficial pelvic floor muscles and the deep pelvic floor muscles. So we have to pay attention to both of those because both of those have very specific functions when it comes to bowel, bladder, and sexual functioning. And then this is just showing a top down so you can kind of see inside. The pelvic floor, unfortunately, is shaped like a bowl, which means it's really hard to teach people how to contract and relax it, okay? When we're trying to teach somebody how to move their arm, it's pretty easy to show them, flexion and extension. How do you teach somebody a Kegel just by talking to them about it? That's really, really difficult. How do you teach somebody to bear down to have an effective bowel movement just by talking about it? So that's where pelvic floor therapy comes in. I do internal exams, both vaginal and rectal, and that helps me get an idea of these deep pelvic floor muscles and what they are doing. You cannot tell what a person's primary dysfunction with bowel and bladder is with just talking to them, by just asking them, well, what are you having trouble with? What are the functions of the pelvic floor? A lot. So we call it the 3 S's. Supportive, sexual, and sphincteric are the main functions of the pelvic floor. So basically, just to go over those really quickly. So supportive, the pelvic floor slings from your pubic bone to your coccyx. It supports everything that goes on in the pelvis. Sexual, we cannot have an orgasm without good, strong pelvic floor muscles. An orgasm is created by a strong pelvic floor muscle contraction. I will argue that sex is an ADL, even though Medicare doesn't believe that, okay? Sex is an ADL. It is an important part of life. And so it is something that we should be talking to our patients about, and it is something that can be helped by pelvic floor exercise. And it is the reason why people bring me chocolate, because I fix it. So it's important to make sure that the pelvic floor is healthy so that you can have a healthy sex life. And then last but not least, we have sphincteric. Our pelvic floor muscles are always activated, always. Unless any of you are actively urinating or pooping on this floor right now, which if you are, we have a problem, your pelvic floor muscles are activated. They are currently working. And that's what holds everything in, closes everything off, and allows us to stay continent. So we have weakness sometimes with that sphincteric, and that's where you have Kegels. But more often than not, what I see in MS is not necessarily weakness, it's overactivity. So these are the patients that tell you it takes me like 5 minutes when I sit down and I gotta run water and I gotta think about something else in order to be able to pee, or in order to be able to have a bowel movement. I have to bear down and I'm sitting on the toilet for 45 minutes. That's due to an overactive pelvic floor muscle. You can give those patients all the Kegels in the world, and what's gonna happen is they're gonna get worse. So you can't tell that just by talking to them. You have to feel that. Okay? There's no other physical therapist that will tell you that, oh, I can do a complete home exercise program and assess a patient without putting their hands on them. I just tend to put my hands in a place that is normally covered up by clothes, that's all. That's the only difference. Now, most people will say, I tell people it's just like looking at a shoulder, and they tell me, no, Carina, that's not like looking at a shoulder. But it is. So, just a little bit of the neuroanatomy. So why does this happen, especially in MS? So, the neurophysiology of the lower urinary tract, meaning the bladder, is essentially an on-off switch. Either you have to pee or you don't have to pee. It's pretty easy when it comes to controlling. We're either storing urine or we're voiding urine. There's no in between, or hopefully there isn't. And micturition is controlled by peripheral neurons that are then coordinated by cell groups in the central nervous system. So our brain, from a peeing standpoint, from a micturition standpoint, is the control center. There's a couple of different places in the brain that are responsible for urination. So our cognitive center is controlled by the periaqueductal gray. That's kind of that area where you feel like you have to pee and you're like, all right, do I make the decision that I'm gonna get up in the middle of this talk and go to the bathroom, or am I gonna try and wait it out until the break? It also exerts control over the pontine micturition center, and that communicates directly with the bladder and tells us whether or not the bladder is actually full enough to trigger the sensation that we need to go, or it suppresses and says, you know what, now is not a good time. Both of these areas in the brain can be affected by MS. And so when they are, sometimes that's where we can do all the Kegels in the world, but it's not gonna really help. We may have to do more behavioral voiding techniques, like something like we call timed voiding, where instead of waiting until you have this strong urge to go to the bathroom, you go at pre-timed intervals that will allow you to empty your bladder when it's just shy of full, so that you're not getting that major urgency or frequency. As far as communication with the brain, the afferent fibers supply information on the relative fullness of the bladder. That signal is routed through the brainstem and the sacral spinal cord, and then the cerebral cortex and the higher brain centers decide basically the urgency of that. The problem that we see with MS is that as they have issues with either the spinal cord, the brain, or the peripheral nerves, they don't trust those signals anymore because they're often wrong. So they'll think that they don't have to go to the bathroom and then they leak. And so that scares people, and so then they go to the bathroom more and more often anytime they get the urge, and that messes with this on-off switch. So they create essentially a behavioral problem to override the neurologic impulses that they can no longer trust. So you can also get loss of voluntary control. And this is one of the times where pelvic floor therapy may not be the only thing that we need. This is one of the times where I do say, you probably need some medication. There's also that heightened sense of urgency. So before the bladder is actually full, it is telling us that we need to go empty it. So within the pons is that pontine micturition center, and that is responsible for controlling our urinary sphincters. What happens when we are, just the general on-off switch of the bladder and the pelvic floor is normally your bladder is relaxed, your pelvic floor is contracted when you're just sitting around and you're allowing your bladder to fill. When your bladder is full, sends that signal up to the brain, higher control centers say, yes, we're going to go to the bathroom. You sit down or stand, the bladder contracts, the pelvic floor opens, you empty your bladder, and then it goes back to that resting state. Where we need medication interventions is if it truly is detrusor instability. So meaning that bladder is contracting uncontrollably when it's not all the way full. That's where we need medication. But what happens is that too often it's really not true detrusor instability, and the only time you can see detrusor instability is on urodynamic testing. So going to see a urologist and doing EMG and urodynamic testing. So too often what people say is, oh, I'm running to the bathroom all the time, I leak a little bit when I have that urgency, let's put them on medication. They try Vesicare, they try Myrbetriq, it doesn't work. Well, that's because it wasn't detrusor instability. Okay, when patients have true detrusor instability, then those medications will work very well for them. We also know that there is some communication with the bladder and the brain through the spinal cord. The info from the bladder goes up through the spinal cord to the pons and then back down, and that is essential for normal micturition. The sacral spinal cord is primarily where the peripheral nerves that supply the bladder and the bowels. So in school we were always taught S2 through 4 keeps pee and poop off the floor, and that's because S2 through 4 are the primary nerves where bowel and bladder function is happening. So as far as innervation of the lower urinary tract, we have both parasympathetic and sympathetic innervation to the lower urinary tract. The easiest way to remember this is the sympathetic nervous system helps you store both urine and poop, and the parasympathetic helps you pee and poop. So stimulation of either of those two nerve pathways is either going to help you store urine or it's going to help you go to the bathroom. So primarily we see the hypogastric nerve and the pudendal nerve are two peripheral nerve mechanisms for urination and defecation. So here's a couple of normals. Normal bladder capacity is about 400 to 600 milliliters of water or liquid. Just to give you an idea of how much that is, these small Fiji water bottles are about 500 milliliters, okay? That's what your bladder should hold. I have one of those, I show patients those and they go, oh no, there's no way that much liquid will fit in my bladder. It should, okay? The first sensation to void, however, is only at about 200 to 300 milliliters. So our first sensation to void is that kind of little mini, like, should I go to the bathroom, should I not go to the bathroom, how much longer is this talk, can I wait, kind of thing. And so that's our first sensation. Our strong urge to void is present at about 2/3. So that's when it starts to get uncomfortable. You guys are all going to have to pee after this talk because I've been talking about the bladder the whole time. But that's where you get that uncomfortable sensation behind your pubic bone. You may start shifting in your chair, doing the pee-pee dance if you're a kid. But that's really where, or you're an adult, yeah, you might do the pee-pee dance, so cross your legs. But that's where your strong urge to void, and that's when your brain starts to tell you normally, we should think about going to the bathroom soon. Now, when you urinate, you should empty your bladder almost completely. A normal post-void residual is about 50 milliliters. I say this because a lot of patients have the perception that I should be emptying my bladder completely. There shouldn't be anything left in my bladder when I'm done urinating. And so these are the patients that will sit on the toilet and they will bear down to get that last little bit out. And they're like, oh yeah, it's just a couple of drops. Guess what? That couple of drops probably should have just stayed in your bladder. It's okay to have a post-void residual, just not more than about 50 milliliters. So what are some of the bladder complications that we see in MS? Bladder issues will be experienced up to 96% of patients with MS. We should be asking every single patient with MS that comes through the clinic about their bladder. However, the most bladder symptoms are not reported until about 10 years after the first evidence of disease activity. So I don't know if it's just that the people in these studies weren't being asked or they didn't feel comfortable enough talking to their doctor. Again, I think there's that perception of who do I go to with this concern? Does my MS doctor care? Does my primary care physician care? Who should I be talking to about this? And so a lot of patients, it just gets lost in the cracks if it's not something that it's primarily that we're talking about. Most common complaints are urgency, frequency, and then urge incontinence. So there's two types of incontinence, urinary incontinence. There's urge incontinence, meaning I'm gonna pee when I'm running to the bathroom. And then there's what we call stress incontinence. And that's your I pee when I cough, laugh, sneeze, jump up and down, move, stand up from a chair. And mixed incontinence is when you have a combination of both. What we see primarily from MS is that urge incontinence, and often that urge incontinence is then what spurs those frequent trips to the bathroom. They're afraid of leaking, and so they go to the bathroom more often because there's this perception, if I go to the bathroom all the time, then I won't leak out, okay? The other thing that we'll see from this is that because they've got that urgency, frequency, and urge incontinence, they don't drink any fluid. Because again, there's that perception of, well, if I don't put anything in, nothing's gonna come out. But I've got news for you, your kidneys produce urine whether you drink or not. So when patients aren't drinking any fluid, what happens is that what is being produced by the kidneys is very concentrated and it's very irritating to the bladder, which is going to cause a detrusor contraction, which is going to cause more urgency and frequency, which is going to cause them to go to the bathroom even more often. And this can get very out of hand. A lot of people kind of dismiss it as oh, that's just mom, she's going to the bathroom all the time again. I had one woman that it got so bad, she was going to the bathroom up to 46 times a day and was literally trapped in her house because she couldn't be more than 3 feet away from a bathroom. So this can get bad. It's something that we definitely need to address. This was another study that showed that 75% of patients with MS report some sort of bladder problem. Of those patients, 70% rate the impact of bladder symptoms as high or stressful. It is one of the biggest factors when you look at quality of life impact. Bladder and bowel issues are one of the #1 quality of life indicators with patients with MS. Urinary incontinence impacts both the patient and the caregiver, and urinary tract infections are a major reason for hospital admissions and lost work for patients with MS. We classify bladder issues into two things. Either you're having issues with storage, meaning, as I was talking about, the overactive bladder, urinary urgency or frequency, or urge incontinence or nocturia, getting up multiple times at night. Or we look at voiding symptoms. These are the patients that have hesitancy. So like I said, they sit down on the toilet. It takes them a little bit longer to be able to go to the bathroom. Poor urinary streams, so they sit and it takes forever for everything to come out. Or if they tell you that their stream splays, so they're kind of getting urine all over the toilet. Whenever I go into a bathroom afterwards and I see urine all over the toilet, I'm like, were you clumsy or do you need my services? Because that is a possibility. Dribbling, so patients that will tell you that they sit down, they think that they're finished with urinating, they stand up and a little bit more urine dribbles out. That is also an issue as far as avoiding symptom. And then that sensation of incomplete bladder emptying. So the patient that will tell you, I walk away, I wash my hands, I walk down the hallway, and I turn right back around because I feel like I have to go again. Your bladder did not refill in that amount of time that it took you to go from the bathroom down the hall. So that is usually some issues with that detrusor instability. From an MS standpoint, there is no correlation between the number of lesions and atrophy and any specific urodynamic finding or bladder dysfunction. So it does not matter whether they're early on in the disease process or late in the disease process. Those bladder dysfunctions can come on at any time. And I've seen lots of patients that bladder dysfunction was their first sign of MS. And it's something that, unfortunately, because it's dismissed a lot just in society in general, I hear a lot of people say, oh, my mom leaked all the time, or oh, my mom had to go to the bathroom all the time. That's just a product of having children. That's not, okay? Leakage is never, ever, ever normal. And so often these patients will dismiss or ignore some of these first signs and symptoms, and it doesn't come out until later on that it was related to their MS. Some of the circuits cited in bladder dysfunction in patients with MS, the medial prefrontal cortex, the parahippocampal complex, and the periaqueductal gray, the insula, and the cingulate cortex. Again, that's where those bladder centers are and those higher functioning centers are. Bladder symptoms can also be due to sacrodemyelinization. Lower extremity motor function is actually the best predictor of bladder function. So the faster that patients have some of that lower extremity issue, increased falls, balance, a lot of that was thought, their incontinence was thought to be, well, they can't make it to the bathroom on time and that's where they're leaking. But there's actually a correlation because when you have weakness in your legs and you have weakness in your pelvic girdle, you probably also have weakness in your pelvic floor. So there's a lot of correlation between those two. However, urinary urgency is also correlated with a high risk of falls. The faster somebody's trying to run to the bathroom that has foot drop or decreased strength in their legs, they're at a higher risk for falls, which is then going to lead to other physical issues. There is a correlation of urinary symptoms with lesions in the midbrain and the pons, and intranuclear ophthalmoplegia also has a high correlation with bladder functions in MS. Some of the most common pattern of bladder dysfunctions, detrusor hyperreflexia, otherwise known as overactive bladder. So that, and you can have two types of overactive bladder. You can have what we call overactive bladder wet, which is where you actually leak with your overactive bladder, and then you can have overactive bladder dry, which is just where you get that sense of urgency and frequency all the time, but you're not actually having any incontinence with it. Overactive bladder dry is one of those ones that really does respond well to medications because it is a true detrusor issue, and it's the fact that the bladder is contracting over and over again when it shouldn't be. Now, detrusor sphincter dyssynergia is a mouthful for what we treat as pelvic floor therapists. So what that is I told you again, there's that on-off cycle. So the bladder contracts, the pelvic floor relaxes to void, and then everything kind of goes back to its resting state. Detrusor sphincter dyssynergia is when those don't line up. So patients will get leakage, but they'll also get starting and stopping because the bladder continues to contract, but the pelvic floor is contracting and relaxing and contracting and relaxing. This is often kind of one of those issues where patients really don't know what their pelvic floor is doing. It's almost a proprioception issue, okay? So just like patients might not know where their foot is in space or have sensation issues in their lower extremity, it's the same thing for the pelvic floor. It's contracting when it shouldn't be. So I'm not treating the bladder, the portion of detrusor sphincter dyssynergia, but I am trying to treat that sphincter dysfunction. It can also lead to high PVR because they're not really emptying their bladder because they can't completely relax that pelvic floor. It's going to result in increase in bladder pressures because that bladder is contracting uncontrollably. Higher risk of UTIs because what happens is that some urine will get trapped in the urethra and stay there, and so then it's going to cause urinary tract infections. And then that can actually cause some upper tract disease into the kidneys because essentially what will happen is you can start to get some backflow of urine up into the kidneys as that occurs. We also will see detrusor hypocontractility and areflexia. People will call this lazy bladder. I don't like to insult the bladder like that, so I don't call it lazy bladder. The bladder's not being lazy. We can't yell at it and tell it to be more productive. It's just that it's truly areflexic. These are the patients that we're going to have to probably work on cathing with, because the detrusor truly is not contracting strongly enough to be able to empty the bladder. They may still be able to go on their own, but they may have to do intermittent cathing throughout the day in order to make sure that they're not getting a lot of extra pressure in that bladder. And that tends to occur from a loss of cortical or cerebellar lesions specifically, because that pontine McDersham center is not functioning. So, as I've said before, you cannot rely on subjective history. Only 47% of patients with a high PVR actually reported feelings of incomplete emptying. So you have to do the PVRs in the office. You have to actually feel what their pelvic floor is doing. Greater disability and recent relapse are associated with increased odds of being bothered by bowel and bladder symptoms. Most of the patients that I see in my office that have MS are usually coming in because they've had a recent relapse. So they're complaining of those new bowel and bladder symptoms when they go into MS clinic, or they're complaining in therapy, and the therapist will kind of trigger a referral. But whenever I see a patient and we work on bowel and bladder issues, often what I'm talking to them about is this is going to get worse if you have a flare, if you have a relapse. Your bladder, even if it's great right now, it may get worse, and then it's probably going to get better again. So we see a lot of ups and downs with bladder and bowel functioning. PVR is usually the only test that most of our neurologists do, and that's great. I'm really glad that a lot of our neurologists do PVRs, because it means they don't always have to go to the urologist in order to see how that bladder is functioning. If they have a consistently high PVR, again, clean intermittent catheterization is often going to be the best treatment. The problem with a lot of the medications that we give patients with bladder dysfunction is that it can worsen cognition. So anticholinergics are usually the number one go-to for those bladder functions. Things like oxybutynin and Vesicare have been shown to worsen cognition in patients with MS and patients without MS. The other thing that we have had really good success with patients with very, very bad bladder and bowel dysfunction is spinal cord stimulators. However, the problem is those are metal. So if you have a spinal cord stimulator, you cannot have an MRI. I have had a couple of patients that have gone that route despite their inability to then have an MRI. One was a very, very young patient of mine, and she was a medical resident, and she was an OBGYN, and she's like, listen, I can't be pooping my pants when I'm delivering a baby. So for her, it was a kind of a quality of life thing. She had the spinal cord stimulator implanted, had zero fecal incontinence after that, and it was something that she said, eventually I will get taken out, but for right now, this is what I needed. And I'm going to get to at the end kind of what we do from a pelvic floor therapy standpoint. Really quickly, though, I want to talk to you about the neurophysiology of the bowel. The problem with the bowel is it's so much more complicated than the bladder. So the bladder is that on-off switch. The bowel has about 8 million switches. And you know this because if you've ever been nervous for a test, nervous about something, that can give you diarrhea. If you eat a bad egg, that can give you diarrhea. If you are flying, that can constipate you. There are so many different outside and intrinsic reasons why your bowel cannot work properly. It's really, really hard for patients to get on a good bowel program. So from the large intestine, it starts at that ileocecal valve, consists of the cecum, colon, and rectum. The principal role of the proximal half of the colon is absorption of water and electrolytes. We have two distinct contractile movements of the bowel. So we have mixing, where essentially it's powerful contractions that facilitates absorption and stool formation. And then we have mass movements, where the peristaltic contractions move the stool throughout the colon. Both of those can be affected in MS, and both of those can cause either, if it's too fast, then that's when you get loose stool. When it's too slow, that's when you get constipation. Some of the reasons why we get constipated, so reduction in neurogastrointestinal signaling, inadequate relaxation of the puborectalis muscle. So we're going back to those pelvic floor. Most of us poop very poorly, okay? So when you see a small child pooping in their diaper, what do? They squat down, right? Only as adults do we basically get into these bad habits and we're trying to reverse that. Kids squat because instinctively they know when I'm squatting down, it is easier to get that poop out, okay? Squatty potty, I'm getting to it. So I'm not a paid consultant for the squatty potty, but I do love it. So the reason why the squatty potty works is because it puts you into that squat position. Our puborectalis muscle most easily relaxes when our hips are flexed, okay? So that's why we put people into that squat position. Inadequate relaxation of that external anal sphincter can also cause constipation. Decreased abdominal tone, preventing an increase in intra-abdominal pressure. So if you have weak abdominals, you might not be generating sufficient enough force to push downward. Or I also see people that just bear down incorrectly. You know, these are the people that I ask them to show me how they bear down, and they close their eyes and screw up their face and hold their breath, and it's like they're trying to push a train out their rectum. It's not. That's not the way you poop, okay? In fact, if you are pooping correctly, you should be making noise. All right? You should be, okay? The reason why is when you make noise, you open up your glottis, all right? You create better downward pressure, you can relax those muscles better, and you can push the poop out. So now when you guys go into the bathroom after this talk, you hear a lot of noise. This is why people like coming to see me, because I try to make poop fun. Another reason why a lot of people will get constipation is something called blunting of the gastrocolic reflex. What happens when we eat is we get a mass movement in the colon. So people who don't eat breakfast lose their gastrocolic reflex. So that's why we joke that breakfast is the most important meal of the day, because it makes you poop. Okay? You should eat something for breakfast. Inadequate fluid hydration. Most of my patients that are coming in with constipation are also coming in with that urinary urgency and frequency. So they're already limiting their intake of fluid because they're afraid they're going to pee their pants, and then it causes them to get constipated. So you have to drink water, not pop, not tea, not water. Not water with lemon, not water with sugar, not water with Crystal Light in it. Water. Stop drinking all that other stuff. Now, you will pry my coffee from my cold, dead fingers. So I tell people, you don't have to stop drinking coffee, but you need to drink water throughout the day. Really quickly, just to talk about sexual dysfunction in MS. The majority of patients with MS are never asked about their sexual functioning. This came from that study in 2015. Many patients experience hypoactive sexual behaviors. And sexual dysfunction, again, severely impacts quality of life, especially with, I will not say anything about our older patients with MS because some of them are having better sex lives than people in their 20s. But, when a patient especially gets diagnosed very young, there's a lot of things, there's a lot of psychological things that go into that hypoactive sexual behavior. There's a lot of worry, but then there's mobility issues. There's the inability to get on and off the bed, or if they're wheelchair bound, or if they have any lower extremity weakness, that can cause some of the sexual dysfunction. Some of the factors that affect sexual functioning: fatigue. Obviously, if you're too tired to have sex, you're not going to want to have it. Spasticity. You can have spasticity in your legs, and you can have spasticity in your pelvic floor. And so that's going to cause sex to become very painful for women especially, because those pelvic floor muscles are so contracted. If they're worried about leaking, so if they're worried about the fact that they're going to have urinary or fecal incontinence, they're going to be less likely to have intercourse. Mood disorders, so any of the other psychiatric issues that can go on. The incidence of sexual dysfunction in MS ranges from 62 to 83%. That is way too high for us to not be asking patients about their sexual functioning when they have MS. I won't go through all of these, but there are a lot of different factors that influence sexual functioning. In men, erectile dysfunction can occur in about 70% of men with MS. The mean time between onset of MS and erectile dysfunction is about 9 years. The ability to sustain an erection is largely dependent on psychogenic erectile drive, but the ability to initiate the erection is usually Viagra, but also pelvic floor muscle strengthening can help with that initiation of erection. With women, we see diminished lubrication, some sensory disturbances. There are very few treatments, medication treatments for sexual dysfunction for women with MS. And we joke all the time that, of course, men are the major players in the pharmaceutical industry, and that's why Viagra exists, and not some Viagra for women, but we won't get into that right now. We also, interestingly enough, Botox for bladder dysfunction has the side effect that it improves sexual functioning as well. So patients that have Botox instilled into their bladder can also have an improvement in sexual functioning. All right, so I've talked a lot about why patients come to see me. So what do I do? First of all, a lot of the education that I just gave you, minus some of the kind of higher level neuro stuff, is exactly what I talk to patients about. A little bit of education goes a very long way when it comes to patients and bowel bladder functioning. There are a lot of myths out there, and I joke that half of my job is just dispelling myths, okay? No, it's not your bladder falling out your vagina. That's called a cystocele, and it's not your bladder, it's the walls of your vagina. No, if you drink less, no, you don't go to the bathroom less. You're just making your urine more concentrated. So a lot of what I do at the beginning is what we just call behavioral retraining. I just so happened that 3 times in a row I had somebody following me, and I had a patient with MS come in for their second visit, go, everything you gave me completely eradicated my symptoms. What are you, some sort of genius? And I usually go, yes. Or as my one patient called me, a vagician. On my business cards. So we all have such bad habits when it comes to bowel and bladder. How many people have gone to the bathroom just in case? Right? Like you're leaving, I don't have to go, but I should just run to the bathroom. Yeah. That is the precursor to urgency, because you just in case void all the time. Okay? So you just in case void when you leave the house, and then you just in case void when you get to the store, and then you just in case void before you leave the store. That's urgency and frequency, and that's not normal. You should be able to hold your bladder for at least 2 hours unless you're drinking alcohol, okay? That's a bladder irritant, so that's gonna make you pee more. Or you've just ingested, over 800 milliliters of water in a very short amount of time. Other than that, you should be able to hold your bladder. Food and fluid management. Most of us are not getting enough fiber. So for women and men, we're supposed to get about 20 to 25 grams of fiber a day to keep our bowels healthy. And patients will tell me, oh, I eat wheat bread. Great. Wheat bread has 1 gram of fiber. So unless you're eating a whole loaf every day, you are not getting enough fiber, okay? That's what keeps your bowel healthy. Eating breakfast keeps your bowel healthy. So there are, and a lot of times it's just making simple food switches. So a lot of patients will say, well, I take Metamucil. I'm not a huge fan of Metamucil or synthetic fiber because it's synthetic fiber. Our body craves natural fiber. So I would rather you eat an apple, which has 5 grams of fiber in 1 apple. There's something to that old adage, an apple a day keeps the doctor away, okay? 5 grams of fiber. So if you have an apple and a cup of raspberries, which has 9 grams of fiber, you've got over half your fiber for the day, and all you've essentially had is a fruit salad, okay? So I would I educate patients a lot about just making these simple changes that can have a huge impact on their lives. And then drinking more water too. So that's another huge question I get is like, okay, how much water should I actually be drinking? There's that whole 8 to 10 glasses a day, and that's very daunting to patients. I usually start them out, I just want you to get 48 ounces of water a day, okay? So I start and I make the goals very attainable for patients, and they are amazed at how just adding a little bit more water, increasing their fiber, and then trying to not give in to that first sensation of urge every single time will completely eradicate both their incontinence and their urgency frequency. Manual therapy intervention, so if they have some spasticity in the pelvic floor muscles, just like we do manual therapy and stretching on other muscles, we go ahead and we do manual therapy on those, on the pelvic floor muscles. Therapeutic exercises, so again, I do more than just Kegels. We do core stability exercises. We do different standing, dynamic, and static exercises in order to try and kick that pelvic floor in. And then mobility considerations. Sometimes they are in a wheelchair, and so we have to think, okay, what's going to be the best way for them to be able to transfer onto the toilet without leaking? How are they going to be able to do that? Bladder diaries are just something that I have every patient fill out, and that just gives me a good idea. Patients often will say, oh, I'm going to the bathroom like 30 times a day, and they fill this out and they're going 5. It's just, there's that perception of what they're actually doing. So this just gives me a really nice visualization of what they're doing. This is the Bristol stool chart. I refrained, there's one that I have that really just compares every food, every type of stool to candy, and I didn't put that one up. But like I said, this one is constipated. This obviously down here is diarrhea. We like people to be in this type 3, 4 range, so either Snickers or sausage. That's really what your food to look like, okay? Behavioral interventions, so again, I talked about the squatty potty. The squatty potty is great, but you don't have to have the squatty potty itself. You can actually just put a stool under your legs, but it does help because people would want to buy a squatty potty for every bathroom. So stool under your legs just to get your legs up in that flex position. If they have mobility issues and they can't get into that squat position, if they can even just lean over and place their forearms on their knees, that can help. Timed voiding I talked about, so going to the bathroom at pre-described intervals. And then something called double voiding. That's for my dribblers who sometimes feel like they walk away and they have a little bit more come out. So I'll have them do something where when they think they're finished peeing, they just kind of stand up a little bit and then sit back down, and they can usually get the rest of that urine out. We talk about abdominal massage for constipation. We do lots of different trunk exercises and core stability exercises, again, just to try and get them to have a better core and be able to control that a little bit better. So anytime I'm next to a fun toilet, this is in Seattle. This is one of the older toilets in Seattle, so I had to take a picture next to it. The real inventor of the toilet, his name was Crap, and so my mug says Crap Happens. So, yes. Do you have a question? Yeah, because I will not be here for the panel, so I think I have like a minute left.
Can you give us like 1 or 2 exercises for your core stability and standing dynamic that you like to use?
Yeah, probably one of the best things that I use is diaphragmatic breathing. So making sure that they can take a deep breath and really expand that diaphragm. And then I try to teach them just a kind of belly button in towards the spine, just stabilization, transverse abdominis contraction.
This may not be specifically in your area, but do you have any thoughts about fecal transplants and MS?
Yeah, so fecal transplants are something that is gaining popularity for issues with constipation and obstructive defecation. The research on there, just on fecal transplants in general, does not really support it unless you've had specifically an infection that has then impaired your enteric ganglia. So yeah, I would, it's not something that I would recommend people explore from an MS perspective. All right, well, thank you very much.